Buenas tardes a todos. Un gusto volver a encontrarnos en esta nueva reunión en forma virtual, en este caso, de la Sociedad Latinoamericana de Endocrinología Pediátrica. Primero quiero agradecer al comité organizador por darme la oportunidad y el honor de poder estar aquí como coordinador de esta conferencia plenaria que estará a cargo de la doctora Lian Ward. La doctora Lian Ward es de Canadá, ya muchos de ustedes la conocen, ha estado con nosotros previamente. So, I am pleased to introduce Dr. Lian Ward. Many already know her, even she has already visited us during our annual meeting in Florianopolis. Dr. Lian Ward is a professor of pediatrics at the University of Ottawa, where she has held a research chair in pediatric bone disorders since 2010. She is the scientific director of the Ottawa Pediatric Bone Health Research Group, the medical director of the Pediatric Genetic and Metabolic Bone Disease Clinic at the Children's Hospital of Eastern Ontario, CHAO, and a pediatric endocrinologist in the Division of Endocrinology and Metabolism at the CHEO. Dr. Ward's research program is dedicated to the study of bone development and the diagnosis of treatment of bone disorders in children, including osteogenesis imperfecta, rickets, hypophosphatemia, and osteoporosis due to chronic illnesses. In 2019, Dr. Ward was named a Fellow of the American Society of Bone and Mineral Research, a Lifetime Achievement Award in the recognition of significant contributions to bone and mineral science. Es un gusto, Lian, volverte a escuchar. It's an honor for us to see you again and to hear your conference. La conferencia será osteoporosis inducida por glucocorticoides en niños y adolescentes, prevención y tratamiento. Thank you, Lian.
Saludos desde Canada. My name is Dr. Lian Ward from the University of Ottawa, and it's my absolute pleasure to speak to you today about glucocorticoid-induced osteoporosis. So thank you so much for this opportunity. I'd like to start by acknowledging my funding sources, as you can see here, particularly the Canadian Institutes for Health Research. And I do have some disclosures and disclaimers. I have been a consultant to sponsors who are working to bring therapeutics to children with osteoporosis and muscle disorders with funds to my institution. And all of the osteoporosis therapies that we'll be talking about today are off-label in children. The only one that's on-label in children is an originate in Italy, but for pediatric osteogenesis imperfecta. So you'll hear me talk today about GIO or GOP, which are the abbreviations for glucocorticoid-induced osteoporosis, and many of the principles that I'll be talking about today I've written about in a recent publication that may interest you. So I'm going to start by highlighting key clinical biological principles of pediatric GIO that inform how we think about diagnosis and how we monitor across a broad range of underlying conditions. Because the different diseases that require steroid therapy are very different from one another, and because the steroid prescription is also quite variable, it's really important to understand the principles that guide the management. And then I'll review data from recent clinical trials that inform prevention and treatment strategies. And I'll finish up by discussing the unmet needs in pediatric GIO that shine light on potential future directions. Now, you're all endocrinologists, so I know you're very aware of the toxicity that steroids bring to the bone and the growth plate. But suffice to say, steroids indeed interfere with osteocyte mechanosensing because they cause apoptosis of the osteocyte. They dampen osteoblast function, so they inhibit bone formation. They decrease renal calcium reabsorption and intestinal calcium absorption. They rev up the osteoclast, at least early on in their administration, and that causes accelerated resorption for a period of time. And steroids are toxic to the growth plate. They interfere with chondrocyte activity. And so, in fact, the growth failure of glucocorticoids is end organ failure most of the time and not usually related to growth hormone secretory status. Now, to think about the way in which bone development goes awry on steroids, it's first best to understand how bone strength develops in healthy children. We know that what drives bone development is mechanical challenges, increases in bone length and increases in muscle force, that those are sensed as bone tissue strain by the osteocyte at a genetically determined set point. The osteocyte then sends signals to the osteoclasts that resorb bone at the site of tissue strain, and then the osteoblasts lay down new healthy bone at that site of tissue strain to reinforce the bone and therefore keep it close in terms of strength to a genetically determined set point. And then puberty and nutrition can also affect the set point and the cascade that follows. Now, when children are on steroids, they don't grow well and they feel unwell, so they don't move as much. And steroids can also, in some cases, interfere with bone and muscle strength development. And so with those diminution of mechanical challenges, there is a loss of bone tissue strain. Any bone tissue strain that is there is not well sensed by the osteocytes because the steroids cause apoptosis of the osteocytes. The osteoclasts are revved up by steroids, as we said earlier. The osteoblasts are dampened, and together this impacts the ability to maintain bone tissue strength in the face of mechanical challenges. And then steroids also attenuate puberty as well. So delayed puberty then results in lack of the normal muscle strength that would come with pubertal development. When I think of steroid-treated disorders in children, in my mind, I divide them into three categories. I think of children with aggressive but transient steroid exposure, like children with leukemia. I think about children with variable steroid exposure, like those with systemic onset JIA, for example, or lupus or a systemic vasculitis. And then I think about children with aggressive and long-term steroid exposure, like Duchenne muscular dystrophy. And it is these three different categories that allow me to think about how best to tailor their monitoring and treatment in terms of whether they actually need monitoring and need treatment. These three categories ultimately determine whether a child has potential for recovery from osteoporosis without bisphosphonate therapy or not. And that's going to be the driving force behind the principles that we'll discuss today. So let's talk about the clinical manifestations of GIO, the potential for medication unassisted recovery that I just mentioned, diagnosis and monitoring, and treatment strategies. Now, much of what we learned about steroid-treated disorders in children in terms of bone health came from the Canadian STOP Consortium, which stood for the Steroid-Induced Osteoporosis in the Pediatric Population Consortium. This was a 6-year study that was carried out longitudinally in 10 centers across Canada. And we learned through that study, looking at children with leukemia, rheumatic disorders, and nephrotic syndrome and other conditions, that vertebral fractures are the hallmark of steroid-associated osteoporosis, that they're often asymptomatic, particularly in their early phases, and therefore they go undetected unless you're absolutely looking for them with, for example, a spine X-ray. So why are vertebral fractures so important? Well, in children, vertebral fractures are associated with back pain, kyphosis, loss of vertebral height, and in Duchenne muscular dystrophy in boys with tenuous ambulation, permanent premature loss of ambulation. In adults, they're also linked to back pain, kyphosis, and loss of linear height, but also reduced lung function, probably because of the loss of spine height, and excess mortality rates. So vertebral fractures are important such that we need to be thinking about them as a hallmark of osteoporosis in the steroid-treated setting. Vertebral fractures are so important that they require a standardized reporting method. We have validated the Genant semi-quantitative method, which critically defines a vertebral fracture as more than 20% loss in vertebral height ratio, whether looking at a wedge deformity, a biconcave deformity, or a crush deformity. We've shown that fractures defined in this way are linked to low and declining spine BMD-Z scores, to back pain, and an increased risk for future vertebral and long bone fractures, regardless of the fracture grade that the vertebral body started with. So even mild fractures of the spine predict future new vertebral and long bone fractures. Here are some examples. This is a mild grade 1 Jeanette defined fracture, a moderate grade 2 crush fracture, and then a biconcave severe grade 3 fracture. And this is the spectrum of vertebral fractures that we see. Most vertebral fractures are like what we see on the left. They're usually anterior wedge fractures, and if we're catching them early, as we should be, then they're mild. Now, one of the challenges is distinguishing vertebral fractures from physiological wedging of childhood. So in childhood, the vertebral bodies are shaped like bullets, as you can see on the left, as the end plates are forming. The end plates aren't yet ossified, and so that creates this sort of bullet-like shape. Now, physiological wedging usually doesn't exceed about 15% in terms of the anterior to posterior height ratio, whereas we just said a fracture is more than 20% loss in the anterior to posterior height ratio in terms of a wedge fracture. Physiological rounding also tends to be in the mid-thoracic region and at multiple levels, whereas on the right, this actual fracture is more angular and it stands out from the other vertebral bodies. Now, when radiologists are not sure if there's physiological wedging or a fracture, they can look for other qualitative signs of fractures like loss of end plate parallelism, anterior cortical buckling, and end plate interruption when the vertebral end plate snaps, just like a long bone would snap its cortex. Vertebral fractures, again, are so important that people have thought about how we can capture vertebral fractures using a rapid low radiation method. And certainly some DEXA machines, particularly the newer generation DEXAs, do have this capacity. They have a C-arm that allows a lateral view. You get the full spine on one cassette without any obliquity, very nice images with the newer machines. And so this is something that we're starting to integrate into our practice. And there have been guidelines written by the ISCD on when to use vertebral fracture assessment or VFA by DEXA in children. We know that vertebral fractures in steroid-treated contexts of childhood have a bimodal distribution with a predilection for the mid-thoracic region and then again at the thoracolumbar junction. We know that the most common site of vertebral fractures in steroid-treated children is around T6, T7. And we know that the most common morphology, as I said, is anterior wedge deformity, although in the lumbar region, we tend to see more in the way of crush type fractures. This is the baseline prevalence and the incidence of vertebral and non-vertebral fractures over 6 years in leukemia. And the first thing you notice is that vertebral fractures in red are more common than non-vertebral fractures. And that's why we say they're the hallmark of steroid-treated disorders. You can see that the prevalence of fractures of the spine in leukemia at diagnosis is around 15%, and then it increases slightly to over 16% at 1 year. So the peak frequency of new fractures in leukemia is at 12 months. And that's when steroid exposure is the greatest. And then the incidence of vertebral fractures by year goes down so that most children are off glucocorticoids by 4 years. So why do we have an increase in both vertebral and non-vertebral fractures between 4 and 5 years after diagnosis of leukemia when most kids are off their steroids? There's 2 reasons. We think that one reason is because they're returning to more normal activities and their skeletons aren't ready. And the second reason is that the kids are growing better, but it takes time to densify bone, and that delay in densification after growth resumes at a normal rate causes a transient bone health fragility. And so I counsel families about that in the first year after stopping their chemotherapy. These are examples of fractures in the leukemia setting, grade 1, grade 2, and grade 3. And overall, we saw a cumulative vertebral fracture incidence over 6 years of 32% in the leukemia population. When we looked at the predictors of fractures, we found that one of the key predictors was, of course, the average daily steroid dose. So the more steroid the child required, the more likely to fracture over 6 years. The presence of vertebral fractures at baseline, including mild fractures in red, predicted incident vertebral fractures later on. And then moderate and severe vertebral fractures at baseline were also a strong predictor of future new fractures over the following 6 years. Declines in lumbar spine BMD Z scores were also predictive, but not as strongly as the baseline vertebral fracture rate. So knowing the spine status in terms of vertebral fractures at baseline leukemia is really important. This is the predictors of incident non-vertebral fractures, so fractures other than the spine. Once again, steroids, but also vertebral fractures at baseline predict future non-vertebral fractures. So again, knowing the vertebral fracture status in leukemia at baseline is really key. And then again, BMD was predictive, but not as strongly so as the baseline vertebral fracture prevalence. Now, what have we learned about the incidence of vertebral fractures and their predictors in children with rheumatic disorders? Once again, we see that the vertebral fractures are most frequent early in the child's steroid treatment course. So this is when, just like in leukemia, the children receive most of their steroid exposure. And then over time, the vertebral fracture rates decline, as does the steroid dose, which I'll show you in a minute. And there's a low background rate of non-vertebral fractures, but certainly vertebral fractures are more common and really the highlight here. So on the top left, you can see that the steroid exposure in rheumatic disorders is greatest in the first 6 months, and then the rheumatologists tend to try to wean from there as best they can and transition the children to other steroid-sparing agents. You see that the BMI goes up in the first 6 months in the bottom left. Top right, disease activity is high at diagnosis and then gets driven down by the steroids. And the lumbar spine BMD Z score in the bottom right goes down in the first 6 months, consistent with the period of maximum steroid exposure, and then has a little bit of recovery, but by 6 years after starting steroids in this population is still not completely recovered relative to baseline. These were the predictors of incident fractures over 3 years in the rheumatic disorders population. Increases in BMI were the strongest predictor. And of course, that's a sign of systemic steroid exposure. Decreases in lumbar spine BMD Z scores in the first 6 months. And then the steroid dose itself was predictive of incident fractures, and an increase in disease activity in the first 12 months also predicted new vertebral fractures over the ensuing 3 years. Now, here's an example of some of these principles. This is a 7-year-old girl with an overlap syndrome. She has a beautiful spine at baseline in terms of her vertebral heights. And then she came back with back pain just 4 months after starting steroids and had multiple fractures. So you can see vertebral fractures as early as about 4 months after starting steroids. Now, her steroid exposure was no greater than the children in the cohort who did not have vertebral fractures. But what was distinguishing about her was that she had a significant increase in her BMI Z score, a sign of systemic steroid exposure, and it increased by 3 standard deviations in the first 3 months. So that Cushingoid appearance is a telltale sign that a child may get into trouble with vertebral fractures. Vertebral fractures, of course, are very frequent in Duchenne muscular dystrophy. They occur in 30 to 50% of boys in a symptomatic fashion, but they're also often asymptomatic, and so very important to monitor for these fractures. And in fact, the asymptomatic vertebral fracture rate in steroid-treated children varies from about 30 to 50% across diseases. So in this situation, you see this boy after 5 years of deflazacort, he has a fully collapsed spine and very little bone on his bone biopsy. So this is serious osteoporosis indeed. Specifically in Duchenne muscular dystrophy, again, we know that vertebral fractures can occur early. We showed that they can occur as early as about 6 months after starting steroids, on average after 2 years. If you do nothing about the spine as it's starting to collapse in Duchenne, it just progresses, and that's called the vertebral fracture cascade, where a fracture at time point A predicts new fractures or worsening of existing fractures at time point B when there is a persistence of risk factors, just like you see in this montage. We know that in Duchenne, that if you're on daily prednisone, that after about 2 years, 4% will have vertebral fractures, after 3 years, 20%, and after 4 years, 40%. If the prednisone is given intermittently, 10 days on, 10 days off, then the vertebral fracture prevalence is reduced, but not absent. However, intermittent prednisone is not as good for muscle strength. So you may try to hold back the steroid exposure, but it will be at a cost to muscle performance, and that's not desirable in this setting of Duchenne muscular dystrophy. In Duchenne, we know the extremity fracture prevalence is about 30 to 60% without steroids, and then double the risk on steroids, and the most frequent sites are the lower extremities, the tib fib, the femur, and then the humerus and the forearm. Now, this is an example of what the femur looks like in a boy with Duchenne, which, as I said, is a frequent site of fracture. And what you can see here is that, yes, the bone density is low, but even beyond the bone density on the left compared to the healthy boy on the right, you can see that the bone is gracile. It's thin in its diameter, and that's an independent risk factor for fractures. And the cortex is also thin. And I mention this because anti-resorptive therapy like bisphosphonates do not make the bones bigger, they make them more dense. And so this is an independent reason for fracture, and long bone fractures can continue in Duchenne despite bisphosphonate therapy. And we're going to talk about that more later. This is an example of a boy who had a tibia fracture at 6 years of age in the steroid-treated Duchenne context. He had fracture management, but went home and came back 7 years later without any spine monitoring in the interim, and his spine was fully collapsed. So his first osteoporotic event was at 6 years of age. And in a child with risk factors for osteoporosis, like steroid-treated conditions, even a single long bone fracture can signal osteoporosis and merit treatment. So you don't, when you're on steroids, need to have 2 or more fractures by 10 or 3 or more by 19. That's for healthy children. In children with risk factors, a single long bone fracture can be a sign of osteoporosis in a child at risk, like a steroid-treated child. Now, what about recovery from osteoporosis? And this is what distinguishes children from adults. Children, through bone growth, can reshape vertebral bodies without bisphosphonate therapy if their risk factors are transient. The prototypic example of that is leukemia, which is an aggressive but transient bone health threat for most. And the reason that they reshape so well, in addition to the fact that the leukemia is usually transient, is that they're young at diagnosis, so they have lots of years to recover in terms of growth. And they're on intermittent steroid regimens, right? They get steroids for a few days of the month, and then they have steroid-free days that allow them to recover. So vertebral body reshaping after vertebral fractures is a key measure of recovery, and we want to think about this because it determines in part whether we treat or not. So if the risk factors are transient, then they have more potential for reshaping. If the risk factors are variable, whether they could reshape or not depends on how much steroid they end up receiving. And if they have permanent risk factors for fractures like Duchenne muscular dystrophy, they do not reshape. So other nuances to describe the potential for vertebral body reshaping: transient risk factors, so less than 3 months of steroids or less than 3 months of immobilization, younger age, so more residual growth potential, and milder collapse. All of that stacks up to the child being more likely to reshape. Less potential if they have prolonged immobilization, 3 or more months of steroids, older age, which we define as over 8 in a girl or 9 in a boy, so once a child is peripubertal or older, they start to lose time to grow and reshape their vertebral bodies. And then more severe collapse takes longer to reshape. So higher fracture grades are associated with less potential for reshaping. Now here's some examples: complete reshaping in a very young child with leukemia. 5 years of age at diagnosis, by 11 years of age, he's reshaped. A 10-year-old girl in the middle, she is not able to fully reshape because she's run out of time to grow and do that. And then a girl who at 15 years of age had already stopped growing, and so her deformity is going to be permanent because she has not grown at all in order to foster reshaping. This is an example of reshaping in a child with a rheumatic disorder. She has JIA, systemic onset JIA. She comes to me when she's 18 months of age. She's got profound vertebral collapse. She doesn't seem to be in a lot of pain. She's weaning her steroids. So I say, well, let's have a look and see if she can recover, because she's not in back pain. I don't need to treat her right away. She had this nice uptake in her growth, which is a good indicator of the potential to reshape in a young child. And over the next 8 years or so, she indeed has gone to have complete vertebral body reshaping without bisphosphonate therapy. And why is that? Because she was young, lots of time to grow, and her steroid exposure was not prolonged. Does reshaping happen in Duchenne muscular dystrophy? And the answer is no. And that is because they don't grow well on steroids. The steroids are usually very long-term. The myopathy is progressive, and that vertebral fracture cascade is in motion. So when we see vertebral fractures in Duchenne, we have to treat right away because we know they can't reshape. They have too many risk factors going against their reshaping. Now, you may say, what if they come off their steroids? Will they get into trouble with their spine? And this is an example of a boy who stopped his steroids with Duchenne at 11 years of age, and 2 years later, he had a vertebral fracture off steroids. And I think it's because that vertebral fracture cascade was in motion, residual to being on steroids previously. So you have to develop monitoring plans that are tailored to the aggressivity of the steroid exposure, the duration of the steroid exposure, and the potential for spontaneous medication unassisted recovery. So people often say, well, when do I do that spine x-ray in order to initiate the monitoring? These are my guidelines that I've published. So if there's transient bone health threats, you do a spine x-ray anytime there's back pain. And then in an older child, a child who's less likely to reshape if they have fractures. In leukemia, you do a spine x-ray after the induction period, so around 3 to 4 months after diagnosis, regardless of the back pain status, to catch those children who have asymptomatic collapse but can't recover on their own. If the bone health threat is variable, like inflammatory disorders, if there's back pain, you do a spine x-ray. If there's no back pain, but they have poorly controlled disease, or they have 3 or more months of steroids, oral or IV, or if they have 2 or more weeks of immobilization or chronic subnormal mobility, then you do a spine x-ray. If they're on long-term steroids and have long-term bone health threats, then you do an x-ray regardless of back pain status to pick up asymptomatic disease in a high-risk child. If they're not on steroids, then you do the spine x-ray once they're older to identify children with fractures who have insufficient residual growth left to recover if they do have a fracture. Now, can BMD help make a decision about who should have a spine x-ray? Know that children can have fractures of the spine at BMD Z-scores better than -2. So the -2 cutoff does not help you decide if a child should have an x-ray. And as well, Z-scores can vary a great deal depending on the reference data that you use to generate your Z-scores. So we do not use cross-sectional BMDs to trigger a spine x-ray. Instead, we use trajectories. And these are examples of trajectories in a boy with steroid-treated Duchenne. We see that the BMDs going down at the spine and at the hip, particularly at the hip, and also getting stagnant here at the whole body. If the BMD over time is declining by 0.5 standard deviations or more, that's clinically significant, and you should do a spine X-ray more frequently than annually, which is what is recommended in steroid-treated children. So you're going to monitor kids who are on 3 months or more of daily oral or IV steroids. You do the spine X-ray annually for as long as they're steroid exposed. You do a BMD every 6 months for as long as they're steroid exposed. And if the BMD goes down by more than half a standard deviation, you do the spine X-ray sooner. You can also do the spine X-ray sooner than annually if the BMI goes up significantly, if the disease gets worse, or if there's back pain. What about children on every other day oral steroids or on high dose steroids for less than 3 months? Well, the rule of thumb is if you see linear growth failure, adrenal insufficiency, significant weight gain with that Cushingoid appearance, this means the child has had significant systemic steroid exposure, and you should be considering doing a spine X-ray to pick up vertebral fractures. And then once you do that, then you're on the pathway to deciding if a child needs treatment. So when do we treat children? When they have at least one low trauma vertebral or one low trauma non-vertebral fracture. You treat them if they have back pain, bone pain, or reduced mobility in that fracture setting, or if they have lack of potential for spontaneous medication unassisted recovery. Kids who are older have more severe collapse or a persistence of risk factors. And this is an example of how this all comes together in a disorder with chronic steroid exposure like Duchenne muscular dystrophy. You do the bone density test I've said every year here, but you would do it every 6 months if the BMD is declining or if they're very high risk. If they're on steroids, you do the spine X-ray every 1 to 2 years, but more often if the bone density drops by more than half a standard deviation or if there's back pain. And then you treat at the very earliest sign of osteoporosis. So let's finish up now by talking about how we treat. So we optimize conservative measures such as identifying and treating nutritional deficiencies. We treat delayed puberty. We address both over and underweight. I talk a lot about fall prevention. I talk about seatbelts in the wheelchair. I talk about avoiding bumpy terrain. I talk about preventing falls and slips on the ice in the winter in both the child and the caregiver. Growth hormone is not routine because of sufficient evidence for benefit and safety in the steroid-treated setting. Unless, of course, their growth hormone secretory status is frankly abnormal, but most of the time the secretory status is not the problem, and the problem is growth plate failure due to steroids. So I just want to touch briefly on the oral versus IV bisphosphonate debate. If all you have is oral agents, then you go forward with that. However, intravenous agents are preferred. And why is that? They're the most frequently used agents in children, so we have lots of experience with them. They're long-acting, which is good in a setting where you don't want to bother a child with frequent infusions or a frequent pill that they have to take on a regular basis. They're better than oral bisphosphonates for spine protection in adults and in children with osteogenesis imperfecta. And this is also looking like it's true in steroid-treated conditions. They're preferred over oral agents in patients with significant risk factors for esophagitis, like steroid-treated children, and they're highly effective for pain relief. They are IV, of course, and they can have significant first infusion side effects. They can precipitate adrenal insufficiency. I've seen that in Duchenne muscular dystrophy, and they can also cause rhabdomyolysis in Duchenne muscular dystrophy. Bisphosphonates, of course, interfere with protein prenylation, and so the ruffled border of the osteoclast loses its shape and loses its ability to resorb bone. We have, of course, IV pamidronate, which is given every 4 hours. It's a little gentler in terms of side effects. It's given every 4 months. And then we have IV zoledronic acid, a little more aggressive with first infusion side effects, given over 1 hour. And my patients are typically on zoledronic acid. With treatment, we're trying to improve back pain, stabilize existing fractures, reduce the risk of new vertebral fractures, reduce the risk of new long bone fractures, and prevent declines in BMD. take care of these side effects. We do supportive therapy, and some children on steroids, even if their doses are already supraphysiological, some of them need extra steroid on top of that with these side effects like fever and nausea and vomiting, etc. They must have IM hydrocortisone prescriptions as well in case they have vomiting with first infusion side effects on steroids, even if supraphysiological in some cases. So what happens when we give zoledronic acid versus placebo to steroid-treated children? This is a study that we did that was international. Children were 5 to 17 years of age and received IV zoledronic acid versus IV placebo. They needed not to have a cancer condition to be enrolled. They were enrolled on the basis of a low spine BMD Z score, well, not that low, less than or equal to minus 0.5, and at least one low trauma vertebral or long bone fracture. Most of the children enrolled in the study had Duchenne muscular dystrophy, and then rheumatic disorders and Crohn's disease was also a reason for enrollment. And you can see most of the children were 12 to 13 years of age. 61% on zoledronic acid had received glucocorticoids during the trial period, compared to only 25% on placebo. So the zoledronic acid group was more steroid exposed. The primary outcome was the change in lumbar spine BMD Z score, which we post hoc height Z score adjusted. And you can see that there is significant improvement on zoledronic acid relative to IV placebo. And the magnitude of that difference was a Z score of 0.75. None of the children on zoledronic acid had low trauma vertebral fractures at 12 months. And 2 patients on placebo had a single low trauma vertebral fracture each. Bone turnover markers declined as hoped for and as expected on zoledronic acid, and they went up on placebo, and that was a statistically significant difference. And of course, adverse events were more common on zoledronic acid. With the first infusion, about 67% on zoledronic acid had side effects, but 25% did on placebo, which teaches us that with first infusions of zoledronic acid, if there's side effects, they might also be disease related and not just due to the zoledronic acid. Side effects with subsequent doses were uncommon beyond the first dose. Gastrointestinal side effects were frequent, and hypocalcemia on the far right was not that common. We made sure all the children had adequate calcium and vitamin D statuses going into the infusion. This is another randomized trial looking at zoledronic acid versus calcium and vitamin D supplementation alone, whereas the zoledronic acid group also had calcium and vitamin D supplementation. And this is specifically in Duchenne. And you can see that, again, the BMD Z score went up nicely, this time over 2 years, and significantly compared to the control group. There were some incident fractures in the zoledronic acid group, about 15% over 24 months, but compared to 24% in the control group. 5 patients in the control group actually withdrew from the study because of incident grade 3 vertebral fractures, and that did not occur in the zoledronic acid group. So although there were new fractures on zoledronic acid, they were not severe like they were in the control group. People often ask me how I dose zoledronic acid. I give 0.0125 milligram per kilogram with the first dose, and then 0.025 milligram per kilogram every 6 months with subsequent doses. I increase to 0.05 milligram per kilogram every 6 months if the BMD accrual rate is not normal for age and gender, or if there's new fractures. And then I go to 0.05 milligram per kilogram annually after epiphyseal fusion. So I really titrate the dose to achieve a normal rate of bone and mineral accrual, like you can see here in this boy. So I'm putting the dose up and sometimes even putting it down if the BMD accrual is excessive, which usually doesn't happen in steroid-treated children. We see that more often in, say, osteogenesis imperfecta. This boy was 8 when he had his first grade 1 fracture in the steroid-treated Duchenne setting. and he was treated with zoledronic acid. I titrated the dose to receive that normal rate of bone and mineral accrual. And then basically 9 years later, at 17 years of age, he has no back pain. He's off to college. He's doing well. He has nice densification of the end plates. But here in the lumbar region, there has been some progressive deformity. And because the BMD has gone up so nicely, I'm not sure that these are classic vertebral fractures here in evolution. I think that the hyperlordosis may predispose to some deformity that we're seeing on zoledronic acid in the steroid-treated Duchenne setting. And this is what the spine looks like in Duchenne over the long term. These are older teenagers and their spines, depending on how they were treated. So these are 3 different patients. The one on the left did not have bone protection, came back after years of steroids and has a fully collapsed spine. This boy was monitored, started on in the middle on zoledronic acid the moment he had the earliest sign of vertebral collapse. And then 9 years later, as you saw on the other slide, he has a pretty good looking spine, although there is some deformity, and he has stayed on his steroids the whole time. On the far right, this boy had vertebral fractures. He came off his steroids. He went on intravenous bisphosphonate therapy, and he grew normally. So he had nice vertebral body reshaping. We cannot promise vertebral body reshaping to any child who is not growing normally. And that is part of the reason why in the middle, this boy has insufficient complete restitution of vertebral dimensions. So let's finish up now in the last few minutes by talking about future directions. Where do we go from here? We know that we need to be monitoring early, identifying vertebral fractures early, and also treating a single long bone fracture, and then continuing bisphosphonate therapy for as long as the children are on steroids. What are the unmet needs that drive how we're thinking about as we go forward? Remember that anti-resorptives like bisphosphonates target bone density. That's what they do. Remember that bone density is most modifiable at the spine and the hip because that's where the bone is more trabecular and porous, and there is room to increase BMD. Remember that long bones are largely cortical bone in composition. The bone is not as porous, and so we can't modify BMD as much. And then remember that anti-resorptives don't at all change bone geometry. They don't increase periosteal circumference, and that is an independent risk factor for fractures. So we need an agent that's going to increase the size of the bone and not just the bone density to prevent long bone fractures in particular. Bisphosphonates are very effective at the spine. I'm talking here about what we need to do to help long bones in this context. So the agent that we all have hopes for is anti-sclerostin antibody. Romosozumab is one such example of anti-sclerostin antibody, and it has both anti-resorptive and anabolic properties. So sclerostin inhibits bone formation on the left. Anti-sclerostin antibody releases the inhibition on bone formation. So it's like taking the foot off the brake and allowing bone formation to go forward. And then anti-sclerostin antibody also inhibits the osteoclasts. It has anti-resorptive effects, and that's good because osteoclasts are revved up early in steroid exposure. Anti-sclerostin antibody is potent. It affects bone modeling, and it does so on 4 bone surfaces: trabecular, intracortical, so we need that, periosteal, making bones bigger, and endosteal, making bones thicker. Now, we don't have any data in kids, so I'm just talking theoretically. In adults, there were some concerns about stroke and myocardial infarction on anti-sclerostin antibody relative to alendronate, and it's not known whether alendronate was protective. We know that anti-sclerostin antibody lacks long-term benefit to bone formation, even if remaining on the drug, so the effect wanes after a year or 2. If stopped, the antibody therapy wears off and BMD and bone turnover markers go back down to baseline, and they're best used before giving anti-resorptive therapy. This is what it looks like in the rat if you give anti-sclerostin antibody. On the far left is no treatment. Second over from the left is the overrectomized rat, and then we have the increasing anti-sclerostin antibody doses in the final 3 montages going towards the right. And basically just track your eyes here at the proximal femur at the very bottom from left to right, and you see that the bone is getting bigger and thicker. And then if you track your eyes at the top, at the spine, you'll see that it's also getting denser. But this increase in bone size and thickness is what we're really interested in here with this drug. And this is some data from adults. Adults with osteoporosis on anti-sclerostin antibody, romosozumab is the name of the drug in this trial, looking at the change from baseline in lumbar spine BMD and total hip BMD. Romosozumab is in the sort of turquoise here, and you can see you get this nice boost in BMD at both sites. If you stop after 2 years, the BMD just plummets. And then you reboost with drug and you can have another boost, but it's not as big as the boost you had in the beginning. So people have looked at bridging the 2 doses of anti-sclerostin antibody with, say, denosumab in red, which is another anti-resorptive therapy, to maintain the gains that were realized in the first 2 years when you treat beyond that. This is a nice montage out of the adult literature. This is adult osteoporosis, just general osteoporosis, not steroid-induced osteoporosis alone. And we see that the best therapy is sequential therapy in terms of benefit to hip BMD, romosozumab followed by a denosumab in this case. And of course, in kids, we don't have a lot of experience with denosumab, so it's not recommended. But I just wanted to make the point that if you use an anabolic therapy like romosozumab, and then you seal in the effect with an anti-resorptive, you get this nice, really significant increase in BMD. So as I go forward, I think about what I've called saltatory sequential therapy. This is purely theoretical. This is just me thinking about what would be very interesting and potentially useful in steroid-treated children who are high risk. I'd love to give them an anabolic agent like romosozumab in the subclinical phase before they have any fractures to prevent first ever fractures, and then seal that in with denosumab, and then maybe reboost their BMD with romosozumab, alternating with denosumab, and do that until they're finished their steroid therapy and sealing all that in with a long-acting agent like zoledronic acid. And I'm talking specifically about children here with very long-term steroid exposure, like Duchenne muscular dystrophy. The other glucocorticoid-treated diseases like rheumatic disorders, individuals are more often being transitioned to, say, biologics and other therapies that are steroid sparing. So I'm really talking about the most aggressive and long-term steroid exposure here, like steroid-treated Duchenne, where the steroids are prescribed in the spirit of virtually lifelong use. So my take-home messages are the following. Osteoporosis is a complication of many chronic illnesses of childhood, both with and without steroids, but certainly steroids exacerbate the risk of osteoporosis. Low trauma vertebral and long bone fractures signal osteoporosis and merit treatment in those with persistent risk factors. The spine should be monitored periodically for asymptomatic as well as symptomatic signs of vertebral collapse. And remember that even a single long bone fracture can signal osteoporosis. Bisphosphonate therapy should be started at the first sign of vertebral or even a single long bone fracture, as I said, in those with persistent risk factors for progression. So early identification and secondary prevention of osteoporosis progression in children with persistent risk factors are the cornerstone of pediatric GIO management. So we have to take care of these children in a multidisciplinary fashion. Your role is to identify and treat early signs of osteoporosis in those with persistent risk factors. These are some articles that I'd be happy to share with you that discuss these principles in more detail. This is my team who's done all the work over many years and for whom I'm extremely grateful. And this is an extended list of the collaborators that we work with. And I want to thank you for your interest in this topic, for wonderful care of children with bone disorders, in your area in Latin America, and for the invitation to speak to you today. And I look forward to the next time we can all see each other once again. Thank you.
Bueno, muchas gracias, Lian, por tu conferencia. Damos inicio ahora a la sesión de preguntas.
Well, thank you so much. It's just really great to be here, and I appreciate the interest in steroid-induced osteoporosis. We still need steroids to treat some conditions, so just really great to be able to talk to you about this today. Thank you.
Hi, Lian. Nice to see you again. Thanks for your wonderful presentation. So we have the first question is, what would be the long-term effects of inhaled corticosteroid therapy on bone mineral density? From Carlos del Águila de Peru.
Thank you for the question, Carlos. So the research shows that fluticasone, for example, less than 800 micrograms a day is safe to bone. Additional information is that I rarely see children on sufficient inhaled steroids to cause bone morbidity these days. In my center, if they're needing chronic high-dose inhaled steroids, they're going on to other therapy, like monoclonal antibody therapy. But generally speaking, as a rule of thumb, if you have a child on inhaled steroids, if they're less than 800 micrograms a day of, say, fluticasone, they're growing well. They do not have any signs of Cushingoid features to suggest systemic steroid exposure, and they do not have adrenal insufficiency, and you have to check for that periodically. Then they're unlikely to have had so much steroid exposure reach their bones to cause osteoporosis. So those are sort of some general rules of thumb that can be used to understand whether a child needs more close monitoring on inhaled steroids. I can.
Thanks.
Okay.
Sorry.
Oh, you go ahead. I wasn't sure if I was supposed to read the next one. You go ahead.
Okay. Veronica Merrick from Chile said, in neuromuscular disorders treated with or without steroids, one of the main effects is a decrease in hip bone mineral density. As you said, BIP do not have bisphosphonates, do not have an effect there. While waiting for anti-sclerostin, what other agents measures you suggest?
Thank you for the question, Veronica. Great to know that you're on the call. So it's true that the hip BMD goes down, and of all three parameters, spine, hip, and total body BMD, it goes down the most, and that's because of the proximal myopathy. On bisphosphonate therapy, if you start early enough, if you're starting early upon first detection of those vertebral changes, you can reverse the trajectory for the hip BMD. If you start bisphosphonates later and the child has progressed in their osteoporosis, but also progressed in their myopathy, it's far more difficult to reverse that trajectory. So early intervention matters. And there's starting to be a lot of conversation about whether we should even be doing anticipatory prevention therapy in boys who have not yet fractured. And we're working on a manuscript right now to see if we can define some of the clinical characteristics that would make you want to say, this is a boy that should actually start bisphosphonates before a first fracture, and thereby keep the BMD up higher from the get-go. So early detection and intervention is absolutely key. The other thing, though, is that ultimately, I think the osteoporosis is going to be best rectified by steroid-sparing agents or agents that have fewer side effects. There is one medication that's in development right now. It's called vamorolone, or VBP15. There is some published literature on this in phase 1 and phase 2A studies. And it is a dissociative steroid that retains its anti-inflammatory processes, but it loses its glucocorticoid response elements that mediate side effects to some extent. And this is an example, it's not approved yet, but it's in development of a steroid, a dissociative steroid that may not be as toxic to bone based on the data that we're seeing in the early phase of its development. So early detection and steroid-sparing therapies, I think, are what's going to protect the bones ultimately going forward. Thanks for the question.
We are going back with the same, similar question about inhaled corticosteroid. Ignacio said, a child with chronic treatment with inhaled corticosteroids for asthma, if he is growing well, can we assure that he has no compromise in bone health?
I don't think it's quite as straightforward as that. I would say I would want to see good growth. I would want to see a lack of any Cushingoid features, a lack of adrenal suppression. So adrenal suppression is a sign of sufficient steroid exposure enough to also cause osteoporosis. And I'd want to see that fluticasone doses, if that's what you use, I don't know if that's what you use in your country, but fluticasone doses that are less than 800. If any of those things are not taken care of or not evolving favorably, then I would do a periodic bone health evaluation. And remember that you get the most bang for your buck in terms of deciding whether to treat or not from a spine x-ray. So the bottom line is you want to know if there's any early signs of vertebral collapse. And if there are, and the risk factors for the collapse are persistent, like ongoing steroids, then you want to intervene. Thank you for the question.
We have two more questions. Veronica again. Once using anti-sclerostin, how would you combine anti-sclerostin and bisphosphonate? Which first?
Yeah, so anti-sclerostin antibodies I mentioned on my slide works best before anti-resorptive therapy, because the benefit is from giving the bones a boost in terms of bone formation, right? And also the anti-resorptive effect. But the main effect you're looking for with anti-sclerostin antibody that distinguishes it from a bisphosphonate is you're looking for that increase in bone formation, like P1NP, and thereby bone modeling. If you give a bisphosphonate first, you not only shut down bone resorption, but as you know, bone formation is also shut down and markers of bone turnover will be low and reflect that. So anti-sclerostin antibody will need to be given first, and then an anti-resorptive agent to prevent the declines that happen when the drug is stopped. And it's only effective in adults for the first couple of years. Yes. So,
Okay. Oscar Bruneto from Argentina. In a patient with Duchenne disease, which is the ideal time to start treatment with zoledronic acid? It could be prior to his first fracture, taking into account that the natural history of the disease.
So Oscar, thanks for the question. And I absolutely think we're headed in that direction. We're headed in that direction. When I speak to audiences such as yourself, I always like to declare what do we know in the published literature? And right now in the published literature, we know what happens when you treat at the first fracture and then go forward with treatment from there. But in Duchenne, where the osteoporotic phenotype is progressive in everyone, it's very logical to think about doing anticipatory therapy in those who are most likely to fracture, starting before the first fracture. Like, I completely agree with you. And as I said, we're working on a manuscript right now, Oscar, where we're trying to look at the factors that are the most predictive of first fractures and then use that to identify boys that we should be treating prior to the first fracture. So give us a year or so to massage that and figure that out, and then hopefully you'll see that, and I'd be happy to chat with that once that data is available.
Okay. Well, we are in time, Liam. We want to appreciate your presentation. I think I will see you next Friday again. So thanks so much, Liam. It was wonderful, your presentation, and thanks for the audience to be part of this presentation with the questions. So bye-bye, and we want to see you again, not online, you know.
Well, thanks again for the opportunity. I really appreciate your interest, and I love being in your presence. So thanks. And I look forward to the next time.
Thanks, Lian. Bye bye.
Bye-bye.
Gracias a todos por las presentaciones y las preguntas. Muchas gracias.